Welcome to the Arthritis Broadcast News. I'm Marilyn Muldoon from the Arthritis Alliance, as well as the Arthritis Research Center here, Patient Advisory Board. This morning I have the distinct pleasure of talking to Dr. Arthur Bookman, who is on the Medical Advisory Board for Sjögren Syndrome Canada, the Sjögren Society of Canada. Dr. Bookman, welcome to Whistler.
Thank you.
We are thrilled to have you here. I just enjoyed Dr. Bookman's workshop down the hall, and I was gobsmacked. I thought I had my questions laid out that I would like to talk to you about, but you brought up so many new and exciting things about Sjögren's that I thought let's talk about them now. But first off, let us explain for anybody tuning in today who may not be overly familiar or maybe just newly diagnosed with Sjögren's, why is it so hard to nail it down, to get that diagnosis?
Well, first of all, I think people have to realize that Sjögren's syndrome is an autoimmune disease. So there's a lot of people out there with dry eyes and dry mouth that don't have Sjögren's syndrome. So this is just one of many causes for dry eyes and dry mouth. And it's difficult to nail down the diagnosis because it takes a lot of specialists to bring all their knowledge together in a coordinated way to get the answer. So you either have to have somebody who strongly suspects Sjögren's syndrome and will quarterback all the investigations that need to be done,
right?
Or you need to have an environment where specialists will share their knowledge, because the patient has to see a dentist, an eye doctor, a rheumatologist, and sometimes other specialists as well, even an ENT specialist to get a biopsy done in order to try to pull together all of the bits of information that come out of that to try to establish whether or not they have Sjögren's syndrome. And the other thing is that, like all rheumatology diseases, the diagnosis is made by criteria. There's no gold standard test you can do for anything, rheumatoid arthritis, lupus, or Sjögren's syndrome. So you have to see whether you meet the criteria, and that's why it's hard to diagnose.
Whose criteria are we using today?
Well, there are a variety of different criteria. The most frequently used are the American European Consensus Group criteria, which have been around since 2002. But very recently, the American College of Rheumatology, along with an international group, have validated a different set of criteria, which are now called the ACR criteria. Both groups of criteria are good, and they seem to validate the same group of patients as having Sjögren's syndrome.
Now, I was delighted to hear that you have a multidisciplinary clinic back in Toronto.
Yes.
Could you explain to those watching and listening today what does that comprise, and are there any plans on having one here in British Columbia?
Well, the multidisciplinary clinic was necessitated by what you just outlined, what you just identified in the first place. It's so difficult to pull it all together.
Right.
So we've organized to bring together an ENT specialist, an optometrist, and ophthalmologist, and and the ophthalmologist is a cornea specialist. Dentist who's actually an oral pathologist, and a rheumatologist. And patients will see all these four specialty groups on the same day. And they have a whole bunch of blood tests done. They have a minor salivary gland biopsy done. And then this entire group meets the following month to pull together all of the information and to identify whether or not the patient has Sjögren's and what would be the treatment plan. And then a big report is put together, and that's sent out to everybody who looks after the patient, so they're all reading from the same prayer book. So you've got the dentist has it, the psychiatrist has it, the family doctor has it, the rheumatologist has it. Everybody knows what's found and what is the game plan for these patients.
Exactly. It's so important for everybody to be on the same page and stay connected throughout the patient's visits for as long as they live, I assume. Right, BC.
Why is it we don't have these elsewhere in Canada?
Yes.
That's why, because nobody else in Canada has my office assistant. That's why.
Oh, maybe clone her.
It's all about the MOA.
You could try. But let me tell you, it's my office assistant is the one that pulls it together.
Oh,
If it
excellent.
wasn't for her, this would have fallen apart years ago.
You know, I think it would be grand if we could start to campaign to get these facilities put together, because so often Sjögren's patients will call me or they'll come to a support group meeting totally frustrated because they've been bounced from pillar to post, from one incorrect doctor to another, or then when they do get the information, it's, you know, or the diagnosis rather, it's perhaps not enough. They're confused, they're worried. You brought up something during the workshop that I thought was very interesting. We're phasing out the terminology secondary Sjögren's now?
Well, the idea of secondary Sjögren's is still well entrenched in these American, European consensus criteria, classification criteria for Sjögren's. But in the new American College of Rheumatology criteria, they have suggested that we no longer use this entity of secondary Sjögren's syndrome. And I think a lot of people agree that it's an artificial delineation. People have Sjögren's syndrome and they have lupus. They don't have one secondary to the other.
In our terminology. I'm finding more and more we're hearing Sjögren's disease rather than syndrome. Are they interchangeable? Are we making a mistake by not delineating them? Or
well,
what are your thoughts?
we use the terminology syndrome when we don't know what the cause is, but we've identified a number of things that happen at the same time in a given patient. So I guess more and more in Sjögren's syndrome, we're starting to understand that the things that happen are from a common cause, like that we're understanding more what's going crazy with the immune system in people. So a lot of people feel more comfortable calling it Sjögren's disease because it's not quite as mysterious in terms of what's happening inside of people. Just like you wouldn't call lupus a syndrome, you call that a disease because you have an idea, even though you don't know the cause, you have an idea of how it's happening to people and what's going on.
This other disease that is called the disease of 1,000 faces. I don't know if did we just call it IgG4?
Yes,
That is
IgG4
often-
related disease.
Yeah, that's often confused with Sjögren's, isn't it?
Yes.
And is there just cause for that, or is that an error?
Well, it's just something that doctors have to be aware of. It's not Sjögren's disease or Sjögren's syndrome. This IgG4 related disease is a condition where there's a certain cell that makes antibodies that grows inside of organs and causes the organ to enlarge and stop working properly. So it's inflammation of a sort. They're white blood cells called B cells, plasma cells.
Right.
So the importance of this diagnosis is that it's identified to us the fact that there's a whole bunch of diseases out there we never understood in the past that all seem to be from the same cause.
Right.
So there's things you never heard of, but people used to walk around with these giant parotid glands, but all their blood tests were normal for Sjögren's syndrome. So we used to label them Mikulic's disease. And there was a lot of controversy whether this was really Sjögren's. Well, it's not. It's IgG4 related disease. And there's a whole bunch of other illnesses like that, like inflammation of the pancreas and certain thyroid problems and lung problems and kidney problems that we couldn't explain before. Now we understand, at least we know they're all from the same kind of cell infiltrating them. We just don't know why it's happening, but at least we can tie them all together now.
Just before the ACR in San Diego in 2013, Sjögren's Foundation of the United States released information that they had just recently nailed 6 Sjögren's related genes.
Yes, well,
What are your thoughts?
I think we're a long way away from identifying the genetic underpinnings of Sjögren's syndrome. These are genes that are occurring with increased frequency in patients with Sjögren's. Whether these genes are important to causing the condition or not remains to be seen. They may just be there because people with these genes may get inflammation more easily. It may not have anything to do with the cause of the disease.
You were just telling us in the workshop about the drugs that one can use for Sjögren's. Would you care to elaborate just a little bit upon what's working and what isn't?
Well, first of all, I think people have to realize that there are not a lot of drugs that work with Sjögren syndrome, and that by and large the treatment is the local treatment to the eyes and the mouth. And if there's complications, we can treat the complications like blood vessel inflammation or whatever. But as far as drugs that actually go towards turning off the dry eyes, dry mouth, the big parotid, we don't have a lot of drugs that we can say for sure are successful. So the only drug recently that's in the last 3 to 5 years that's raised interest has been this rituximab, which is a man-made protein that targets a certain kind of white blood cell called B cells and takes them out of action. And since these cells are very intimately involved with the inflammation in Sjögren syndrome, we had hoped, and we still hope, that this dampens down the inflammation at least for a good long time after the treatment's given. So the initial trial was very hopeful, that it was good, and then just recently there's been a publication in the Annals of Internal Medicine that demonstrated that the drug was not effective.
Oh.
So we don't know what the truth is yet. It may be
Okay.
somewhere in between.
Would this rituximab be something along the line of methotrexate when someone is newly diagnosed with RA? Would rituximab be something that when a person is newly diagnosed with Sjögren's that you would want to introduce, or is it only when it becomes more systemic?
Well, you'd have to prove that rituximab was tremendously effective and cost-effective and safe before you'd use it in early Sjögren syndrome, and that just hasn't been shown well enough yet. Whereas methotrexate, even though potentially it could have been a dangerous drug, has turned out to be relatively safe and very effective in the majority of people who use it for rheumatoid arthritis. So that just hasn't proven to be the case in rituximab, which is very, very expensive.
When we were discussing ocular therapies and whatnot, you broached the topic of optic nerve damage.
Yes.
Now that really struck a chord with me, being a Sjögren's patient, because whenever I visit my ophthalmologist, he says, "Marilyn, how often are you using your drops?
Yeah.
You are so bone dry. It's getting perhaps close to corneal ulceration time." And in truth, I think, well, gee, I know they're dry. I'll think about it maybe 4 or 5 times a day, but by then it's already too dry. What happens? What happens with this nerve damage?
Well, to be precise, what I described was corneal nerve damage, not optic nerve damage.
Okay, sorry.
It's a very important distinction.
All right, corneal nerve damage.
Well, it's important because
It is.
your optic nerve, if that was damaged, you would go completely blind.
Absolutely blind, right, sorry.
So your corneal nerve provides sensation to your cornea. So if you get a
Right.
little fleck of dust on your cornea, you blink, right? So we find that we can actually visualize those nerves using a special microscope. And we find that in people with Sjögren's, those nerves start to die away. So people may not even appreciate how dry their eyes are. They may not feel it. And so when you don't feel something, you don't protect the part.
Right.
And then you get accelerated damage as a result.
Exactly.
That happens actually in diabetics as well, and maybe in some other conditions.
Serum tears.
Yeah.
Could you explain serum tears, and is it a costly process? Is it for just when a patient is going into perhaps corneal ulceration, or is it something that we should be using on a daily basis?
Well, it's not easy to access tears made out of serum.
Okay.
So you have to have an ophthalmologist, usually a cornea specialist, usually somebody who's hospital-based, who's got the facilities to make up this preparation. It's made according to a protocol, and basically it's used in people that have refractory damage to their cornea, ulcerations in the cornea or the white of their eye, the sclera. And what we do is we draw blood and we spin it down, we take the serum off and get rid of the cells. And then by adding some preservatives and whatnot, we put the serum in vials and we give the patient an eyedropper. They take it home, put it in the fridge, and they use it 3-4 times a day in their eyes. And it seems to be, there's something about it that allows these ulcers often to heal, whereas artificial tears and normal other measures we use don't work in those circumstances. So it's it's a thing you do for advanced eye problems and refractory eye problems.
And it is expensive.
Well, it takes a lot of people to do it, so
Right.
you either the hospital budget's going to pay for it, or you're going to pay for it.
I was wondering whether it was covered under people's
No.
provincial medical.
No,
It's not in Ontario?
No, this is not like a commercial entity.
Right. Stem cell therapy for Sjögren's. What are your thoughts?
Well,
Stem cell
there's
therapy
been
for
some
everybody.
trials of doing stem cell infusions. So these are fetal stem cells. So they're taken out of the umbilicus of the baby,
Okay.
and then they're multiplied thousands of times. They're grown in culture, and then they're infused back into the patient through an intravenous. The publication was just recently, and the abstract was 2 years ago at the American College of Rheumatology. The patients responded according to their trial amazingly. It's like tremendously dramatic response in every measure for their Sjögren's syndrome. So we're waiting to see more answers. This was also used, the same method was used for lupus patients who also seem to respond. The reason why it works is open to a lot of discussion, but it appears that stem cells infiltrate these diseased organs, and they play a role in controlling the immune cell infiltration into the organs. So if you reset the thermostat with these stem cells, it seems to turn off the disease. So it's very early, and
Yes.
the reports come out of Japan, and nobody knows what to think about it yet. So keep your radio on.
Am I correct in understanding that in order to utilize the stem cells, we have to shut down the immune system?
Well, you're talking about a bone marrow transplant in people that have malignancies, where
Okay.
you're going to wipe out the malignancy
Oh,
first
okay.
and then give it. But not in this case, no.
All right. Will it be in my lifetime we'll see these stem cell therapies?
Well, if it's going to turn out to be dramatic, you're going to hear about it probably pretty quickly. But we're waiting to hear more information.
That's great. Is there anything we can do as consumers to help you? Spread the word, help with our researchers here in requesting specific target ideas. Is there anything we can do to help you, Dr. Bookman? You're doing so much for us.
But here's what I think needs to be done.
What needs to be done?
I think that patients with severe Sjögren's syndrome need to create a lobby to get the health plan to pay for their needs.
Yes.
The health plan has let them slip through, and it doesn't cover most of what they need. Patients with Sjögren's syndrome require intensive and expensive dental care.
Yes, we do.
There's no coverage for that.
No, there is no.
Patients with Sjögren's syndrome need artificial tears. There's no coverage for that. And sometimes they need access to biologic. There's no coverage for that.
Right.
So people with Sjögren's syndrome need to get together a lobby, and they need to go to the various ministries of health across the country and make them understand that these are special patients where the health dollars need to go towards their care. And even when it comes to dental implants,
Yes.
it needs to be paid for. So
It is very true. It is, in as much as it, for the most part, is an invisible disease, it's a very expensive disease.
Very.
Just out of pocket. It costs people sometimes upwards of $1,000 plus per month for their varying needs. And if they have the,
I have patients
the-
spend $20,000-$30,000 on their teeth just to
Yes.
try to maintain them. So
Yes,
this should be covered.
Yes, it should be.
And I think it's just plain ignorance on behalf of the healthcare system. Nobody really cares that there are these special patients out here, and patients have not pulled together to make noise about it. And it won't help for the doctors to do it.
This is the problem. You've hit on something that is a problem that I see on a regular basis. People either come to the support groups or they phone in, and they are talking about their disease as if it's nothing very important. In many cases, they have been told by a rheumatologist that isn't in the know that yes, they have this autoimmune problem, there's nothing to be done, I don't need to see you anymore. They also may be women of advanced age who are now grandmothers, and they're looking after their children, their grandchildren, whatnot, and they just feel that, well, why bother at this point? I've been living with it this long. What's the big deal? What are your thoughts?
Well, I mean, in fact, we've actually looked at this, and we did a quality of life questionnaire using a number of validated tools that psychologists use to measure the quality of life. And in patients that had Sjögren syndrome, they measured their quality of life as badly as people that were on dialysis and as badly as people that had multiple sclerosis.
I had heard that.
So the quality of life impact is far more severe than what an individual patient is saying. Most people are miserable.
Any other closing thoughts, Dr. Bookman? Have you anything that is on your mind about Sjögren's that maybe we didn't cover today that you'd like to talk about?
I think that patients do need to organize and be a little more vocal
Yes.
in their needs. That's
I agree.
That's the message I want to leave you
I
with.
agree. What are you hoping that the folks that were in your workshop, what are you hoping that they leave Whistler with today?
So I think they will respond more readily to patients when they know there's something they can do. So I think that's the idea of this workshop.
Excellent. I thank you so much for your time. It's been a pleasure and an honor meeting you, Dr. Bookman.
Thank you. Same here.
Keep carrying that torch for us. We're counting on you, kid.
Will do.